Center AIIMS. Welcome, Dr. Shiva. So we have Dr. Shivanand and Dr. Atin Kumar joined by Dr. Richa Yadav from the Division of Radiology. Please, I'm handing over to you to start the session. Thank you.
Thank you so much and for this kind introduction, and thank you to all my colleagues and friends of trauma surgery department here for holding this annual conference. And we always look forward to this annual meeting in the year. In every year, it has been held since last, I think 2008, we are holding this conference. So I'm glad to be a part of it. And it's at the outset, I will just like to tell, I'm sure all of you know that it's
Dr. Atin, आपकी आवाज थोड़ी कम आ रही है.
Okay. At the outset, I would like to tell that this is a teamwork which we actually do at our center. We not just do a diagnostic radiology, we are working together 24 hours, hands in hands with our clinical colleagues, especially the trauma surgery and the orthopedics and the neurosurgical team, to give diagnosis of these conditions when the imaging is done live, as well as we also take part in decision making. I would like to tell that the trauma clinicians, the trauma surgical team usually
Dr. Atin, आपकी आवाज नहीं आ पा रही है. Please.
Okay. Just a sec. I'll just. Hello. Hello.
Yeah, we can hear.
Okay, but the volume is less. That's what you're saying.
Dr. Shikma, can you hear?
Yeah, it's better now, sir.
Okay, is it better now? Hello.
Yes.
Okay.
Yes, sir.
Okay, fine. So I was saying that we work as a team with the trauma surgical team closely hand in hand, and we discuss the cases as the imaging is done so that the management of these cases is done live. We serve as a part of the team in the decision management for the patients based on the imaging. Obviously, the clinical part is seen by the trauma surgical team, but we help by seeing the imaging. And one very good example of this discussion, besides being done live at the time when the patient is being scanned, is the trauma radiology conferences, which we do officially twice a week. But if you ask me, these trauma radiology conferences, mini conferences, are done almost every day at a level when the cases which are in the emergency then and there are discussed. So we will in this next 1.5 hours or so show you a glimpse of how we go about in discussing in the rounds, the trauma radiology rounds, about these cases which have been done in the last couple of days, usually at every time. So I'll hand over to my surgical colleagues who will be presenting the first case, and then me and my colleague Dr. Richa here, aided by Dr. Shivanand, would be taking you along the radiology of these cases, and we'll discuss as we go along. Okay, so I'll start my screen share. Okay. So let's start with case 1.
Good afternoon, everyone. We'll be presenting to the radiocon of last week. Today's case number 1 is an unknown patient. He was a 30 years male with alleged history of unknown mechanism of injury. He was brought by CATS to our trauma center ED. On arrival to ED, area was threatened. He was immediately intubated and put on mechanical ventilation, and cervical spine was stabilized. He was spontaneously breathing with a respiratory rate of 16 and saturation of 94. Chest bilateral air intake was equal and clear. Chest compression test was negative. He had a pulse of 70 per minute and BP of 130 by 70 mmHg. Pelvic compression test was negative. Patient has a GCS of E1, V1, M3. Pupils, he had anisocoria, dilated one side pupil. On adjuncts, EFAST was negative. Chest X-ray and pelvic X-ray were both normal. On secondary survey, there was a deformity and swelling in the right side of the leg. CT, head, cervical spine, and torso for discussion.
Okay. So as you've seen from the history, the patient has a significant injury, and with the GCS which was low, so we did a CT of head, cervical spine, as well as the torso in this particular patient. Okay, we'll start with evaluation of the CT head in this particular patient. And as you can see, while I'm scrolling down, we can see there is a large area of parenchymal hemorrhage seen in the right frontal lobe in this particular patient, with extensive edema around the hemorrhage, parenchymal hemorrhage. There are extensive fractures of the right maxillofacial region. When I'm talking about the head, there is specifically fractures of the right frontal bone with underlying extraaxial bleed which is present. So with the associated fracture, this underlying bleed is likely to be a EDH. There's also a component of SDH in this particular case, in this particular patient, but this is EDH, SDH in the right frontal convexity, right frontal parenchymal hematoma. And as we go on the superior surfaces, superior sections, we see that there is a SDH along the right parietal convexity also, a small SDH seen on the left parietal convexity also, and a small SDH along the midline falx posteriorly. This hemorrhage is causing a mass effect and contusion, mass effect over the underlying right lateral ventricle with some midline shape. Besides that, there is also extensive injury in the, once we do the bone window, we see there is extensive injury in the mid face. So there is injury to the maxillary sinuses, the anterior, lateral, as well as the medial walls, injury to the fracture of the right zygoma, fractures of the nasal bones, ethmoidal bones, superior as well as inferior parts of the right orbital apex. And as we go down, if we do the bone window, we can see that there are multiple skull base fractures also. So fractures of the skull base also, which is seen in this particular case. As a routine protocol, then we would run through the cervical spine in this particular case. For cervical spine, we typically like to see them in the sagittal and the cornal reformats. So I would make a sagittal reformat, and that's how we typically look at the cervical spine. We just scrolled it. There was no significant injury seen in the cervical spine. The alignment was maintained. No fracture was seen, and the the chest tube, the tube is seen in situ. In the patient is intubated, and the tube is seen normally in the position. So after that, we go ahead with the torso CT. As we are scrolling up, in our center, for most of the cases with significant injury, we acquire the torso in two phases, in the arterial phase as well as in the portal venous phase. Especially the chest is acquired in the arterial phase. Okay. As I'm scrolling down in this particular patient, right from the top, you can see that there is a endotracheal tube is seen in situ, which is normally positioned. Bilateral lung parenchyma shows basal atelectasis on both the lower lip, lower dependent segments. Okay, there is a right pneumothorax which is seen. As you can, I'm sure you can see that there is this pneumothorax which is seen on the right side. There's no chest tube in situ. This is some aspiration changes which are seen in the dependent parts of the lung parenchyma. This is expected since there is significant maxillofacial injury in this particular patient. Some amount of blood would have aspirated. There are some conditions in the peripheral part of the lung parenchyma on the left side. Okay. As I come to the abdomen, this is the arterial phase which I am still seeing. Arterial phase, we typically want to see the abdomen just to look for the vascular anatomy and any active arterial bleed which is present. It is not a good phase to comment upon the parenchymal injuries. So I'll use this phase just to comment upon the active bleeding. And as I'm scrolling down, I could not see any active arterial bleed in this particular patient on the arterial phase. So to look at the venous phase for the parenchymal injuries, this is the venous phase which I have loaded. Now you can very clearly see, we can see the parenchymal injuries better. So this is the liver. We can see in the right lobe of liver, there are multiple large areas of contusion as well as lacerations, predominantly involving the superior segments of the right lobe of the liver. This is reaching up to close to the parenchymal hepatic veins, but there is no active contrast exposition which is seen. There is also a peripheral contusion, which is leading to a capsular rupture on the right side and a small hemoperitoneum, which is seen adjacent to the liver in this particular patient. The spleen is looking fine. The pancreas, adrenals, IVC, portal veins, gallbladder, kidney, they're all looking fine in this particular patient. And as we go down, we can see that there is some free fluid in the abdomen. So there is hemoperitoneum. So we know that only there is a solid parenchymal injury of the liver. With the extent of the injury, this would be classified as around grade 4 liver injury according to the AST grading with hemoperitoneum. Rest of the solid organs are normal. I also want to look at whether or not there is any bowel injury. In this particular patient, I am not finding any signs of pneumoperitoneum, and there is no abnormal bowel segment which I could localize in this particular patient. The pelvis appears fine. So my complete diagnosis in this case would be a significant head injury, maxillofacial injury, EDH, SDH, multiple SDH in the head with parenchymal contusions with some mass effect and midline shape. Cervical spine being normal, aspiration changes in the lung, right occult pneumothorax, and grade 4 liver injury with hemoperitoneum. Okay, back to you, Parvez.
Okay, what was the management for this patient, Dr. Parvez? Can you hear me?
Yeah, ma'am. As the patient has severe head injury, this patient was taken to OR by neurosurgery team. We had put intercostal tube drain on the right side as the patient was on mechanical ventilation. And for that, we have put the ICD on the right side. And patient was shifted to OR directly. And then after that, patient was shifted to ICU in the neuro ICU. Patient is doing well. Patient was M3 initially. Now patient is M4 this time.
And how about liver injury?
For liver injury, patient was managed non-operatively from our side. We had done the routine USG in this patient after the 5th day of injury, and which was not showing any increase in the hematoma or any pseudoaneurysm. So we'll be non-operative from trauma surgery side.
Okay, you can go ahead to the next case.
So thank you. With this, we'll go to the next case. You can read from there only.
Good afternoon, everyone. Second case, Mr. G, 27-year male. He had a history of RTI, two-wheeler hit non-helmeted rider, hit with an unknown mechanism, brought to us by cats. On arrival, airway was patent, cervical spine was stabilized. He had a respiratory rate of 24 with SpO2 of 98%. Chest compression test was negative, and bilateral air entry was equal and clear. He had tachycardia on presentation of 134 with BP of 57/32, that is hypertensive, and he was given a 1-liter fluid challenge and also 2 PRBC. And with that, the tachycardia slightly worsened, but the BP improved. He was pelvic compression positive, and he also had a right femur, right thigh swelling. So we splintered the fracture and also applied the pelvic binder. He had a GCS of full score with bilateral pupils, normal size and reacting. Fast positive in hepatorenal and pelvic window with chest X-ray normal and pelvic X-ray suggestive of bilateral SPR-IPR fracture with right SI joint involvement or disruption. And he also had, as I said, the right thigh swellings, which was splinted, and he had a laceration of the thigh. We attempted a single Foley's catheterization per urethra, but that failed. Over this period, the patient again crashed and his BP dropped to about 88/50. So we took him up for damage control surgery in view of a transient responder. There on laparotomy, we found that patient had a zone 3 hematoma reaching up to zone 2, which was non-expanding. And we also found about 800 ml of hemoperitoneum in the pelvic cavity and stellation rupture of the dome of the bladder. This was repaired. And for the pelvic, bilateral internal iliac was ligated and peritoneal pelvic packing was done. And along with SPC of the bladder after the bladder repair with skin closure. After that, the patient was shifted to ICU with the damage control resuscitation. Post that, once the patient stabilized after almost 28 to 32 hours, he was taken first for a CT to evaluate the head. And during this procedure, the cervical collar was still in situ. He was shifted for CT imaging for head, spine, and cervical spine evaluation, and then taken up for the DB look. So the head, NCCT, head, C-spine, and crossover discussion.
So we'll start with the head CT of this patient. So, there is, as we can see in the head CT, there is small focal area of bleed in the perimesencephalic cistern in this particular patient. So there is SAH and some parenchymal contusion here. As we go up, we can see there is some bleed along the tentorium also in this particular patient. And the rest of the brain parenchyma is actually fine in this particular case. So there is small SAH in this particular patient and small tentorial bleed, which is like a SDH in this particular patient, but no mass effect, no brain condition. The cervical spine actually in this particular patient was also done, and this is the sequence of the cervical spine. As I've told you, we would typically scroll the cervical spine in the sagittal reformats. So I'll make a sagittal reformat for the cervical spine, and on scrolling the alignment looks fine, mainly the vertebrae looks fine, but as you can see that there appears to be a fracture disruption at the level of the craniovertebral junction. So this is the C1 which is fractured. Just to evaluate it better, I went on back to the axial images, and as I go up, this is at the level of the craniovertebral junction. As I can see, there is a fracture fragment of the atlas. So there is a fracture of the anterior arch of the atlas, fracture of the posterior arch of the atlas, as well as the right lateral mass, which is jutting inside the canal. So this is a classical Jefferson's fracture, in fact, a high grade type 4 of a Jefferson's fracture with compression into the canal. So this patient would typically be having some deficit because of this particular fracture in this particular case. The rest of the cervical spine was normal. Now, evaluation of in this particular case, the torso evaluation actually we did start from the head only, from the because of the Jefferson fracture. We also wanted to evaluate the status of the neck arteries. The neck arteries are fine at the level of the Jefferson fracture. The vertebral and the carotid arteries were completely fine. So there was no vascular injury at this time, at this point. But when we went into the thorax, actually, the mediastinum appears fine. The main lung parenchyma are appearing fine, but there is mild hemothorax on the bilateral. Right, slightly more than left. So mild hemothorax is seen in the pleural cavities. No rib fractures were seen, no lung parenchymal injuries, or no pneumothorax was seen in this particular patient. When we come to the abdomen, again, I am talking about right now about the arterial phase. As informed earlier, I just wanted to comment on vascular bleed on the arterial phase, not exactly on the organs. So there was no vascular injury on the arterial phase in this particular patient. As I come down in the pages, there are some packs which are seen. I will just show you these packs and the findings better on the second phase, which is the venous phase which we take. This is a venous phase which I've loaded. So I'll scroll it back again. Ignore these artifacts. This is some artifacts which are coming because of the hands lying to the side of the patients. These are slightly unavoidable. We typically like to do the CT with the heads over the head. But in this particular patient, if there is head injury, if the patient is not conscious, or if because of any reasons the hands cannot be taken over the head, they have to lie on the side. They may lead to some streak artifacts. As a radiologist, we should know that these are artifacts and not injury. So the liver is fine in this particular patient. The spleen is fine. As we go down, you can see that there's a right big adrenal hematoma. This is the right adrenal gland, which is significantly enlarged. This is the left adrenal gland, which is the normal. The right adrenal should also have been of this side, but this is a big right adrenal hematoma. As we come down, there is a laceration in the upper pole of the kidney with a perinephric hematoma. This is all hematoma which is seen. And as I come down, there is perinephric hematoma which is seen. So once I see this laceration running through and through, if it is more than 1 centimeter, it will classify as grade 3 renal injury minimum. I also need to evaluate whether the PCS is involved in this case or not. If the PCS is not involved, it is grade 3. If there is a pelvic alicizal system injury, it is grade 4. In this particular patient, the pelvic alicizal system was not involved. That we can evaluate by taking a delayed phase, which we took in this particular patient, and there was no pelvic injury. I'm not showing you for the lack of time. There is a right retroperitoneal hematoma. As I can see, the right psoas is bulky, bulky. There is bleed along the right paracoelic gutter, and as I come down, I can see a abdominal drain in situ in the pelvis, and in the pelvis I can see multiple surgical packs which are placed. So these are surgical plaques which are placed in situ. These are the radiopaque wires which are actually present in the surgical plaque. This whole is a complete pack which is present in the pelvis. This is especially present in the properitoneal space, in the space of tracheus actually, and in the pelvis. And as I can see, there are multiple pelvic fractures in the form of bilateral superior as well as inferior pubic rami. There is injury to the right sacrum. On the left side, there is a zone 3 sacral injury. On the right side, there is a fracture of the right iliac blade posteriorly. Some opening up of the right SI joint is seen. This is the normal left SI joint. This is the right SI joint, which is opened up. To visualize it better, what we can do is we can play around with our images. We can make thick sections like this, and it gives us a global picture of the amount of pelvic injury. As we can see, there is significant sacral injury as well as superior and inferior pubic rami fracture. And because of this hemodynamic, probably because of this, there was a hemodynamic instability and a pelvic bleed for which the patient was taken up for a damage control surgery, and these packs were placed. Now at this time, we cannot see any active contrast leak. So, and the patient was stabilized. Therefore, he was sent actually for the CT scan. So at this time of the CT scan, we cannot see any signs of active bleed even in the pelvis. The packs are seen well placed in situ. Although there is presence of hematoma in the pelvis, which was expected because of this multiple pelvic fractures. I think that's it.
Dr. Atin, I just wanted to ask one question, rather two questions. One is that it is a standard approach that if the patient is unstable, we normally take them for pelvic packing, and that is what was done in this particular case. When we remove the packs, we at times also get a prophylactic, or rather, I would say, adjuvant angioembolization of the bilateral internal iliacs. So would that help in such cases in which already a pack is there, or is it impossible to do angioembolization?
Okay, to answer your question, it is a good question. First of all, once the packing has been done and the patient gets stabilized, it depends upon the if in spite of the packing there is continuous lack of maintenance of BP or no proper response to the fluid challenge, then we can go in and supplement your packing by doing a pelvic angioembolization. In this particular case, and usually that more often that is the case, as I've been told, at the time of damage control surgery, the bilateral internal iliac arteries are already ligated. In this particular scenario, if the arteries are already ligated, we don't have a role for doing the angioembolization after doing the packing, because our access has actually already been blocked, because you have taken care of what we were supposed to do. In any particular case, if you have not done the internal iliac artery ligation, in those particular cases, especially before removal of pack, there can be a role for doing the angioembolization in taking care for the small branches of the internal iliac artery, and we have done that in past also in those cases. Or if we see of active bleed and we can pinpoint the artery, we can still try and go in and do a selective embolization of that particular vessel, which is causing bleeding in spite of doing the packing. Or there are scenarios when the packing has not been done. As a primary interventional radiology can play a role in taking care of the bleeding as an alternative to doing a pelvic packing. If the expertise, if the time is available and at hand, and if the IR guy is available at the time when you are thinking in terms of doing some intervention for saving the patient because of the condition.
Yeah, just one more question regarding the cervical spine fracture. You showed a very classical, unstable and a complex kind of a Jefferson fracture here. In general, would the neurosurgeons like to do MRI also in such cases, or this is frank enough for them to have an idea of the surgical procedure they want to do?
to answer that question, what in our experience I have seen, typically for planning of the surgery, the CT is good enough. For the extent of injury, the CT is good enough. But if you want to evaluate the status of the cord, then a MRI definitely supplements, because you cannot assess that on a CT alone. Sometimes the cord status is clinically evident by the neurological deficit, but the neurosurgeons still want to document it in the form of how much is the extent of cord injury before the procedure, so that then once they do the procedure and do a follow-up imaging, which is best done by a MRI, they would have a baseline uh, evaluation of the extent of injury, so that they can compare how much is their gliosis, which is persistent, or how much is the wall. But if there is no neurological deficit to start with, usually they would maybe avoid an MRI only, and they can go ahead and operate based on the CT imaging.
Thank you.
Our
Thank you.
usual cervical collars don't hinder into the assessment of such neck injuries, cervical spine.
So the CT as well as the MRI can be done with the collar intact, actually.
With the-
And I just wanted to add in this particular patient, once we did a delayed scan also, because there was significant injury to the pelvis and there was hematuria, and there was also a history of the repair of the bladder during the time of the operation. So a delayed scan was done, which showed that there was suprapubic catheter in place in this particular patient. The bladder was irregular in outline, but there was no leakage of contrast from the bladder in this particular patient. Only in the lower part of the perineum there was leakage of contrast which was seen, and that was because of the RGO which was done prior in this patient, and there was a urethral injury actually seen in this particular patient. From that there was a leakage of contrast which was done because of the urethral injury. That was pre-procedural contrast which was still remaining. So we can, I think, move on to the next case. So this is case number 3. Okay. Who's presenting? Parvez?
Case number 3, Mr. B, 42 years male. He had alleged history of RTI. He was a pedestrian hit by 4-wheeler. On arrival to ED, airway was patent, cervical spine was stabilized. He had a pulse rate, respiratory rate of 18 per minute and a saturation of 98. Chest bilateral air entry was equal and clear. Chest compression test was negative. He had a pulse of 134 per minute and a BP of 117 by 59 mmHg. Pelvic compression test was not negative. Patient has a GCS of E4, V5, M6, and pupil were bilateral, normal and reacting to light. FAST was positive in the hepatorenal and pelvis. Chest X-ray and pelvic X-ray was normal. Pelvic X-ray was showing left side neck of the femur fracture. On secondary survey, there was deformity in the left side of the thigh. There was also diffused tenderness per abdomen and guarding also. And CCT torso for discussion in this patient.
As we can see, the patient is a high-speed injury, pedestrian hit by a 4-wheeler, which we consider as a dangerous mechanism. The EFAST was also positive, although the GCS is fine. In this particular patient, just let me pull out from our packs. So a quick scroll through the head CT showed the head was normal, there was no injury, and similarly the cervical spine was fine in this particular patient. So I'll just directly jump to the torso imaging in this particular patient. So this is the torso CT which has been done in the arterial phase. As I scroll down, I can see that there is some mediastinal hematoma which is present, and once I'm scrolling down, I can see at the level of the proximal descending aorta, specifically at the level of the isthmus, there is a irregular contour to the aorta with the outpouching of contrast which is seen. You can see this. This is the outpouching of the contrast. This looks like a dissecting plaque, but this is actually leak of contrast outside the aorta, and this is a dissecting pseudoaneurysm which is being formed. You can see this flap here. You can see the flap here, and this is outpouching. So this is a dissecting pseudoaneurysm seen at the proximal descending aorta, specifically at the level of the isthmus with some mediastinal hematoma present in this particular patient. I will just show it better on the corneal and the sagittal reconstructed images. But in this axial images, when I'm scrolling down, what I also see is presence of bilateral hemothorax in right as well as left pleural cavity. Once I do a lung window, I can scroll up and down to see there are no lung parenchymal changes. So the lung parenchyma is pretty fine in this particular patient. Okay. Just to show it better, the aortic injury, this is the sagittal reformats. And as you can see clearly, this is the arch of the aorta. This is the descending aorta. At the junction of arch and descending aorta, at the level of isthmus, there is this dissecting pseudoaneurysm, which is irregular contour of the aorta with outpouching, both on the posterior as well as the anterior aspect, with this some dissecting flap which is seen. So this is a dissecting pseudoaneurysm, the typical location of a blunt aortic injury. We also need to tell whether it is active contrast succession or not. There is no active leak into the mediastinum. This is outlined, and so there is a pseudoaneurysm. This is the left subclavian artery which is seen, which is the last branch of the aortic arch. We also need to actually measure the distance from the subclavian artery from the start of this pseudoaneurysm. In this particular case, the distance was around 2 centimeters. I have measured it and I am telling you it's around 2 centimeters in this particular case. This is important for the management, because as a management, we usually go in and do a stent graft placement. We need to know how much is a landing zone available for us so that we do not occlude the origin of the left subclavian artery. Going back to the axial images in this particular patient and going for the evaluation of the abdomen. As I go into the abdomen, I can see the liver is appearing fine, the spleen is kind of appearing fine. There is a big right adrenal hematoma which is present as was seen in the previous case also. Okay. As I go down, the kidneys are appearing fine. As I go down, the upper part, the pancreas is appearing fine. As I further go down, what I can see is that there is a large area of altered signal intensity seen in the region of the mesentery. There is hyperdense bleed, which is seen in the region of the root of mesentery lower down, with fat standing adjacent to it, right? So this makes me think that there is a big mesenteric hematoma in this particular patient. There is also free fluid in the abdomen. I want to look back now at the signs of bowel injury. Since I'm seeing a mesenteric injury, there is no pneumoperitoneum. I'm particularly looking at the non-dependent parts. There is no pneumoperitoneum which is seen. Then I want to evaluate all segments of the bowel per se. As I'm evaluating all segments of the bowel, you can see that this is the normal mucosal enhancement of the bowel. This particular bowel segment just shows slightly thickened walls. Okay, I'll show you maybe better on this venous space. As I come down, you can very clearly see this is the normal mucosal enhancement of the bowel wall. As I come down, this particular bowel loop is showing a thickened wall. There is edema in the wall which is thickened, but however it is enhancing fine. This particular bowel wall is enhancing fine. But if I look at this particular bowel segment, as you can see, there is no enhancement of the mucosa of the bowel wall. The wall is papery thin. In fact, it is imperceptible. This bowel loop is just adjacent to the site of the mesenteric bleed. So this bowel is normal, the mucosa you can see. This bowel is engorged. You can see thickening of the mucosa and the wall. This particular bowel you do not see. This is again the normal thickened bowel, but this particular bowel segment you cannot see any enhancing wall, papery thin. This makes me think that probably there is a ischemia of this particular bowel segment. I can try and correlate it with my corneal also. So this is the corneal.
As a panelist, वो आपको virtual MNC करके जो बंदा है ना, वो आपको upgrade करेगा आधे घंटे.
There is a mesenteric hematoma which is seen. This is engorged bowel. This is the bowel which is proximal to the site of the vascular injury of the mesentery. This is the normal bowel which is distal to it, and this particular bowel segment is completely non-enhancing with a papery thin bowel wall. Still, it has not breached its adventitia or there is no pneumoperitoneum, but
So Dr. Atin,
if I can understand correctly, in this patient, largely he has aortic injury and intra-abdominal injury in the form of some bowel injury.
And mesenteric.
So you have a high index of suspicion for intra-abdominal injury in the absence of pneumoperitoneum.
In the absence of pneumoperitoneum, so if I'm talking about bowel
So
injury,
in the absence of pneumoperitoneum, are there signs of intra-abdominal injury? Yes.
so there is free fluid in the abdomen, as we can see.
Yes.
Free fluid in the abdomen, the hepatorenal pouch. There is free fluid in the pelvis also. Free fluid in the abdomen and the pelvis. My first aim is to look for any solid organ injury. This particular.
So that's what I'm asking. So in the absence of the solid organ injury, the free fluid is there, then it should alarm us, and that's what I'm asking.
Bowel injury or a mesenteric injury.
Or the mesenteric injury. That's what I'm asking.
Or the
So-
most short sign for a bowel injury is pneumoperitoneum, which is not present in this particular patient, but there is a
But how?
mesenteric is present
That's
And-
right.
and a non-enhancing bowel movement. Yeah.
So is this patient is hemodynamically stable?
The patient,
Yes, sir, patient was hemodynamically stable.
Stable because he has undergone a CT scan. So
Yes, sir,
he
he
is
was-
the patient who requires evaluation of the abdomen, further evaluation of the abdomen. Either so he can be taken up for diagnostic laparoscopy.
Actually, patient has frank features of peritonitis in the ED. So it was
Okay.
decided to take the patient for exploratory laparotomy.
Okay,
We had done
okay,
the
okay, okay,
laparotomy
okay.
patient.
Okay. So upfront there was indication for exploratory laparotomy. Fair enough. Okay.
signs also for bowel issue.
Dr. Atin? Yeah, many a times we have also seen that when we have a injury to the aorta, you would get a ECG gated CT done. What is this ECG gated CT and how is it better than the normal CT?
Usually, if you want to ask me, if a good quality arterial phase CT has been done, then typically we can evaluate all the major vessels, including the aorta, pretty well on a arterial phase CT itself, and we can diagnose the aortic injuries pretty well. If there is any doubt of being an aortic small minimal flap in the aorta, whether it is there or not, especially because of the motion artifacts in the level of the chest, especially at the ascending aorta or the root of aorta, it may give rise to some artifacts which we may think or wrongly diagnose them as dissection flaps. In those particular patients, actually, it is a good idea to repeat the CT with a cardiac gating. What a cardiac gating done is, it is synchronized with the ECG with the part of the cycle in the diastolic phase. So once you are acquiring all sections accordingly synchronized with the CT, then those movement artifacts, because of the pulsation of the heart, are taken care of. They do not come into the picture. And after that, if you see any what looks like a flap, then we are sure that it is not an artifact. It would truly be a flap, and we can diagnose an aortic injury. But that's practically done when we have a doubt after doing the first CT.
Yeah.
Otherwise, this is good enough to do a planning. Also,
Okay.
for the most common treatment for such patients is usually an endovascular graft repair, the TEVA, the transthoracic endovascular repair of graft. For that, we also know the exact dimensions for the approach vessel, which is usually the femoral or the iliac vessel or the last aorta. So if you have done a CT scan which is completely evaluated in the arterial phase, the entire distal aorta, the iliacs and the femoral, that is good enough. Otherwise, you might require to repeat the CT just for the evaluation of the approach vessel for taking in that particular.
Sir, I have one question. Sir, usually how much centimeter of the landing zone is essential to place an endovascular stenting?
Okay. The more landing zone you have, the better it is. But typically, the stent grafts which are available for aortic injury have a segment which is a non-covered segment, one part, which is around 1 to 1.5 centimeters, and then the covered segment starts. Yeah. So if we have a complete landing zone of more than 1.52 centimeters from the uh, origin of the 2 centimeters from the subclavian artery origin, then it is good enough. We can even put the non-covered part beyond the origin of the subclavian artery, and it will give a good stable result. If we have a landing zone which is less than that, we still can do a TEVAR. We can still put a stent graft. What happens is we put the covered part of the graft beyond the subclavian artery, and the uncovered part of the graft overlaps the origin of the left subclavian artery. What it does is it still allows the blood to flow into the subclavian artery, but since there are some strands, it might decrease the some amount of flow, and in the long term you have a chance of some thrombus formation on the stents and may leading on to an embolic, which we ideally want to avoid. But if that is not the option, then we can go ahead and do it. In worst case scenarios, even the left subclavian can also be uploaded and covered in the stent graft. If that's a life saving procedure, if that is done, then we also see that there are injuries or there are mechanisms in which the proximal subclavian gets uploaded and the arm can have a good still distal runoff. But as a life-saving procedure, even if that's required, that can also be done.
So can I just quickly ask one question to Dr. Amit? So there are some like situation like this. See, he has an abdominal injury, and for the benefit of postgraduates who are listening this, attending this workshop, and he has a aortic injury. So sometimes it's a dilemma that should we take him straight away for laparotomy, or should we go ahead with the TEVAR first and then laparotomy? So Dr. Amit, what's your take on this?
Well, very simply, abdomen is a Pandora's box. Abdomen is a cavity in which if a bleed starts occurring, it can accumulate massively. And that is the region where intra-abdominal bleed can become really uncontrollable, whereas intrathoracic bleeds, especially from the aorta, are contained bleeds. And therefore, if a patient has arrived in your hospital and he was stable enough to get a CT scan done, then probably it would not bleed him to death. So I think the logical sequence would be to initially get the laparotomy done away with and stop the bleeding or any other sources of contamination in the abdomen. Maybe if it is a damage control, leave the abdomen temporarily closed and then go ahead and tackle with the aorta. That's what my take is.
No, I think the message is very loud and clear for all the postgraduates, because it looks very scary that patient has a aortic injury, but it's contained and the patient has reached to the hospital and underwent a CT scan. Can we move to the next case, please? Yeah.
So next case, Mr. S, 21-year male. Case number 4. He is a 21-year male with the alleged history of pedestrian hit by a heavy motor vehicle. On arrival, airway was patent. Respiratory rate of 20, the cervical spine was stabilized. He had a respiratory rate of 22 per minute and SpO2 of 96%. Air entry was decreased on the left side and the chest compression test was positive on the left side. He had a tachycardia of 102 per minute and BP of 117 by 85 mmHg. He was GCS full score with positive pupils, normal size and reacting. First, he was positive with left side lung spanning absence, suggestive of pneumothorax, left-sided, with fluid in hepatorenal, sphenorenal, and pelvis space. Chest X-ray, left-sided pneumothorax present. For this patient, we put a left-sided ICD and a check X-ray was also done, which showed decrease in the pneumothorax, and pelvic X-ray was suggestive of left vestibular fracture. On secondary survey, he had abrasions on the right periorbital area with subconjunctival hemorrhage and an immediate abrasion on the chest. NCCT, head, C-span, and also for discussion.
So in this particular patient, the head and the cervical spine was normal actually. So I'm not showing for the lack of time. In the abdomen, I'll just straight away jump to the torso. Okay. So this is the CT of the thorax. As we can see that there is, okay, I'll show you the lung window first. There is pneumothorax on the left side, for which a chest tube has already been placed as told in the history. There are multiple rib fractures. This is the bump in the rib here, bump in the rib here. So multiple mid part single point rib fractures. The chest tube is seen in C2 in the normal position. There is significant left hemothorax, which I'm showing you better on this mediastinal window. There is mild right hemothorax also. There are basal atelectasis of both lung fields. The left lower lung is showing collapse also, and there are some areas of contusion in bilateral mid parts of the lung. In fact, upper lobes also. These are areas of contusion. These are the parenchymal opacities, basically ground glass type of opacities, which are seen in the parenchyma, consistent with contusions. This is a collapse and atelectasis. This is hemothorax bilateral. This is pneumothorax on the left side, and the multiple rib fractures which I have shown. When we come to the abdomen, the liver is grossly appearing fine, but on the left side, as we can see, the spleen is absolutely not visualized. What we can just see is a margin of the splenic capsule or the parenchyma, but the entire spleen is not enhancing except for this small, very small fragment of the spleen which is showing enhancement, and this fragment. This is maybe a small splenunculus which is seen. So there is a complete non-enhancement, that is devascularization of the spleen. If I'm seeing this, I wanted to look at the splenic vessels. If I look carefully, this is the splenic vein. As I see the splenic vein, there is a big thrombus sitting in the distal part of the splenic vein. So the distal splenic vein shows a thrombus, and this is the splenic artery. The splenic artery was seen going up to the hilum, and then there were no vessels seen within the splenic parenchyma. So there is splenic vascular injury at the level of hilum, both arterial and venous injury, leading onto a complete devascularization of spleen, which is a grade 5 splenic injury. There is no area of active contrast accession seen in the splenic parenchyma. Besides that, what I also see is that the left kidney is also showing predominantly non-enhancing area, especially in the upper pole. There is a marginal part of the upper pole which is seen. Otherwise, the entire upper mid pole of the kidney, and I'm going to the lower pole, is showing non-enhancement. Only a very small part of the lower pole is showing enhancement. Rest of the kidney is again devascularized. I can only see the capsule of the kidney. And if I want to trace the cause for this, I have to look at the main renal artery. This is the left main renal artery. Just as it takes off from the aorta, after 1 centimeter, there is a complete cutoff of the left main renal artery. This is the most common site for a blunt vascular injury to the renal pedicle, which is usually within 1.5 to 2 centimeters after it takes off from the aorta. On the comparison, I can show you the right renal artery is absolutely fine. The right kidney is enhancing absolutely fine. There is minimal perinephric hematoma which is present on the left side. So you would think, why is some part of the kidney showing enhancement and the rest is not enhancing if there is a complete cutoff of the left renal artery? The answer also lies in tracking back that there is this small vessel which is going and enhancing which is going and supplying the enhancing part of the kidney. If I trace this vessel back up, I can trace it actually back to the aorta. So there is an accessory renal artery which is arising from the aorta, a very small accessory artery, which was the reason that some part of the kidney parenchyma was showing enhancement. If I'm looking at the kidney injuries like this, it's a good idea to do a coronal reformat and look at grossly at the amount of injury. This is the right kidney. The left kidney lower part is enhancing, the upper part is non-enhancing, the spleen is also not enhancing. So this will make it as almost a grade 4 to grade 5 renal injury, grade 5 left splenic injury, no active contrast accession, minimal perinephric and perisplenic hematoma which is present, or bleed which is present, and there is hemoperitoneum in the pelvis, which I am seeing right till I'm going down. There is significant hemoperitoneum in the pelvis, and there are pelvic fractures also in the form of superior and inferior pubic rami bilaterally. which are present in this particular. So my final diagnosis would be a grade 5 splenic injury, around grade 4 to grade 5 renal injury, left pneumothorax, bilateral pneumothorax, left ICT in situ, bilateral lung contusions, and hemoperitus.
Can we check?
Sir, what about the pancreas, sir? What about the pancreas? Am I audible, sir?
Body of the proximal body of the pancreas shows a small focal laceration in the region of the proximal body of the pancreas. This is this non-enhancing part in the proximal body of the pancreas. So this is the laceration. Adjacent and anterior to it, there is a small fluid collection which is seen in the lesser sac also. So this presence of this collection in the lesser sac should also make us especially look for the pancreas, and there is a pancreatic laceration. What is more important to classify the pancreatic injury into a grade is whether or not there is involvement of the pancreatic duct. On the CT, either we can clearly look directly at the pancreatic duct, but many times when the pancreatic duct is not dilated, it is not visualized on CT, like in this particular patient. Then what we take as a surrogate marker is the extent of parenchymal injury, which is present to look for whether or not there is pancreatic duct involvement. So if there is laceration, and if the laceration runs more than 50% of the entire width of the pancreas, in this particular patient, we can see that it is running from the anterior surface almost more than 50 to 75% of the width of the pancreas. I presume that there is most likely a involvement of the main pancreatic duct, especially if there is an extensive collection seen in the lesser sac anterior to the pancreas. That also makes me believe that there is a high chance that the pancreatic main duct is involved. So I write actually there is a grade which makes it actually a grade 4 pancreatic injury. Any injury in the body of the pancreas with involvement of pancreatic duct makes it a grade 4 pancreatic. So there is grade 5 splenic injury, grade 4 pancreatic injury, grade 4 to 5 left.
So Parvez, what was the plan for this patient?
The pancreatic injury, this patient was shifted to OR. Actually, laparoscopy was done in this patient. It was seen that there was complete transaction of the pancreas at the level of proximal body. So distal pancreatectomy was done in this patient. Also, the spleen was shattered. So along with the distal pancreatectomy, splenectomy was done in this patient.
And it was post-injury day what? After how many days he?
Same day, sir.
Same day.
Same day, yes, sir.
Okay. Right.
And any comment on the laparotomy when for the renal injuries, retroperitoneal organs?
So retroperitoneum was not explored in this patient. There was no urinoma, there was no hematuria in this patient. So retroperitoneum was not explored in this particular patient.
Sir, Dr. Atin sir, sir, what is the role of MRI during evaluation of such a traumatic injuries, and when should we specifically advise MRI in such a patient?
The role of MR in abdominal trauma is very limited, but in our experience and as per the literature, what we've used MRI is specifically for the diagnosis of pancreatic injuries. We do not use it for any other solid organ injury or as expected for hollow viscous injury. If there is a pancreatic injury, CT sometimes may be having a doubt whether we are seeing a laceration or not. And if there is doubt on CT whether the duct is involved or not, then we take the help of MR. MR helps in two ways. Because of the better contrast resolution of the MR, helps to better characterize the laceration or a contusion of the pancreatic parenchyma. Secondly, as we are all well aware, MRCP is a very good technique for evaluation of the pancreatic duct. So if you are wanting to look at the injury of the pancreatic duct, we can do a MRCP and we can see whether that laceration is going through and through involving the duct or it is not involved. So by those projectional MRCP images, we can better characterize the involvement of pancreatic duct if we are having any doubt on the CT scan. I would also like to add here, in our experience, and we published that in literature also, that we all know that the pancreatic injuries evolve with time. So sometimes when the imaging, the CT or the MR is done at the time of acute injury itself, let's say in the first 24 hours, there would not be a complete manifestation of the entire extent of pancreatic injury. If we just follow it up, maybe 1 day, 24 hours or 48 hours later, then there is time for the injury to evolve, the pancreatic enzymes to leak out, the fluid to collect in that laceration, the laceration to widen up. And if we do especially MR at that time, we can see a better extent of the injury, better evaluation. If the patient is undergoing a non-operative management in the first 2-3 days, then we can always do a MR to better characterize those injuries.
Hello, sir. Sir, can I ask a question? Hello, Dr. Atin, sir.
Yes, yes.
Sir, had this patient had it been that situation that patient was having no pancreatic injury, that patient was having a grade 5 splenic injury, right, sir? So, sir, would you do this the prophylactic angiomulation for this patient when this patient was not having any indication of laparotomy for grade 5 splenic injury? So, in other words, what is the role of prophylactic angioembolization in solid organ injury? So, it was also a question from audience, sir.
Fine. So it's a very good question. We in our experience, as well as according to the literature, the role for interventional radiology in splenic injuries is pretty high, and it has been extensively used. The most definitive indication for interventional radiology in splenic artery is when there is a higher grade splenic injury, let's say a grade 4 or a grade 5 injury, especially because of the contrast extravasation. If there is active arterial contrast extravasation, or there is a vascular injury in the form of a pseudoaneurysm or AV fistula, it is shown that a intervention by splenic artery embolization helps to take care of the bleeding and prevent splenectomy, because otherwise the surgical treatment remains a splenectomy. So the most definitive indication is a reasonably stabilized patient with a CT evidence of an active contrast extravasation. With the revised AST grade, active bleeding has been incorporated in the AST grade itself, where grade 4 and grade 5 splenic injuries incorporate the active bleeding into the peritoneum also. That is a definitive indication. If there is no active bleeding present on the imaging and there is still grade 5 splenic injury, as an alternative to splenectomy, we can do a prophylactic embolization, and it has been shown that these decrease the rate of secondary splenectomies or relux splenectomies in this particular set of patients. So in our center, we do prophylactic angiomolizations in grade 4 or grade 5 injuries based on various circumstances. If you are asking in this particular patient, this is a grade 5 splenic injury, but in this particular patient, there is no role for splenic artery embolization. Why? Because this is grade 5 because of devascularized spleen. If the spleen is already devascularized, if the renal artery is already avulsed, then this is not a bleeding spleen. This is a devascularized spleen. So there is no role for embolization in this particular patient. Embolization is a measure for hemostasis, for bleed control, and for preventing a splenectomy. But if the spleen is already devascularized, we will not go ahead and do a embolization in this patient. I hope it answers. Is that clear, Soumya, Dr. Soumya? You have to
Yes, sir. Thank you, sir.
So, do we go on to the next case?
Next case is Mr. H, 42 years male. He had alleged history of RTI. He was a two-wheeler, helmeted, has bike skid. On arrival to ED, area was patent, cervical spine was stabilized. He was breathing spontaneously, has a respiratory rate of 18 per minute and saturation of 99. Chest compression test was negative. He had a pulse of 85 per minute, a BP of 110/70. Pelvic compression test was negative. Patient was had GCS of E4, V5, M6. Pupil bilateral was normal size and reacting to light. EFAST was negative, and chest X-ray pelvic X-ray was normal. CCT torso for discussion.
Okay, again, in this particular patient, I'll go straight ahead with the torso CT because the findings were there in the torso CT, not in the head or the cervical side. I'll go straight to the abdomen because that's where the findings lie. As we are seeing, we are in the evaluation of the venous phase of the abdomen. The liver is fine, the spleen is fine, pancreas is fine. As we come lower down, this is the right adrenal. So the right adrenal is bulky and is showing a hematoma. This is the left adrenal. Compare it to the left side. The left adrenal is fine. The right adrenal is bulky and showing a hematoma. As we come lower down, there is some perinephric fat standing and there is a hematoma around the kidney. As you can see anterior to the kidney, there is some bleed or fluid seen in the hepatorenal pouch also. As I come lower down, there is a laceration running through and through the kidney in this particular patient at the lower pole. This laceration is more than 1 centimeter in width and running across the entire width of the kidney. So this is at least a grade 3 renal injury with perinephric hematoma. As I told you earlier, the differentiation between grade 3 and grade 4 renal injuries in such cases is whether or not there is involvement of the pelvic calyceal system, which we cannot decipher on these particular set of images. What we need to do is we need to take a phase, which is excretory phase, which is usually taken around 8 to 10 minutes after this first phase, when the kidney starts to excrete the contrast. And at that time, we will evaluate the pelvic calyceal system. But what I'll just complete, we just go lower down and evaluate the rest of the bowel, the mesentery, which is all appearing fine. There is minimal right retroperitoneal hematoma. This is tracking from up onwards from the perinephric space. It is tracking along and going into the right side lower into the pelvis. As I come lower down, the pelvis is appearing fine and there is almost no free fluid in the peritoneal cavity also. So it's predominantly a right perinephric hematoma, right renal injury, right adrenal injury. What I would then do is I would take a delayed phase. So this is a delayed phase which has been taken in this particular patient. How do we confirm? We can see that there is excretion of the intravenous contrast by the calyceal system. I can see it in both sides. When I come lower down, what I see is that from this lower calyx, this contrast, the excretory contrast is leaking out into this perinephric hematoma. As you can see clearly, this is the contrast which is pooling outside in the perinephric space. So there is clearly an injury to the calyx and to the system. What I can do is I can play around with my computer parameters and I can clearly show you this site of leak from the calyceal system into this perinephric space. So this is the extent very well clearly seen. What I can also do is I told you earlier, we can do a coronal reformat which clearly shows this. So this is the pelvic calyceal system, the upper calyx, the middle calyx. From the lower calyx, there is this leak of contrast into the perinephric tissue. This is the excretory contrast which is present. So this classifies this as a grade 4 renal injury because of involvement of the pelvic calyceal system and a right adrenal hematoma, and that's the complete diagnosis in this particular patient from the imaging point of view. Back to you, Dr. Parvez or Dr. Preksha.
So next case, case number 6.
Excuse me, sir. There are some questions appearing from the audience section. Sir, one question has been asked that what is the gold standard investigation to detect pancreatic injury? Another question is what is the role of prophylactic angioembolization in context of liver injuries? Thank you, sir. This first question I will direct to Dr. Atin, sir. Both of the questions. Thank you.
So I have kind of already answered the first question. We do not directly suspect only an isolated pancreatic injury to start with. Any patient who comes with a blunt abdominal trauma, we do suspect, we have a clinical suspicion for pancreatic injury, but we also want to look other parenchymal injuries. CT will always remain the first investigation to do in any particular patient. CT is pretty good enough to actually pick up any reasonable amount of pancreatic injury. Only thing is, happens if it is done too early in the phase. As I've told you, the pancreatic injuries evolve with time, too early in the phase, and there is very small pancreatic injury. CT may be equivocal or doubtful. In those patients, we can supplement it with MR. MR does not substitute a CT, but it just supplements or complements a CT imaging. We do not just do only a MR to look at the pancreatic, right? So the MR is good, but we complement or supplement the CT, not do it in isolation. To answer the second question, in liver injuries also, the more or less the mechanism remains the same. If there are evidence of vascular injuries in the liver in terms of either active contractilation or pseudoaneurysm, there is a good role for doing a angioembolization. If there is no vascular injury which is detected, only a high grade, grade 5 injury, we often take it on a case-to-case basis. If we see extensive shattering of the liver parenchyma with significant hemoperitoneum, we can go ahead and do a prophylactic angioembolization. If we see one particular vessel which is bleeding during the time of DSA, we particularly embolize that particular vessel. If we are not able to find any particular bleeder, but just a diffuse blush, what we often do is put a gel foam and do packing of gel foam from the distal branches of the hepatic artery so that it can help in taking care of the bleed at that particular time. The gel foam usually resolves on its own 3 to 4 days of time. By that time, we believe that the body's own mechanisms will take care of it. So there is a role for prophylactic embolization in high-grade liver injuries, lesser than splenic injuries, I would say.
Thank you, sir.
Then case 6. Next case.
Case 6, Mr. T, 25-year male. He presented to us with a history of fall from third floor. On arrival, primary survey, airway was patent, cervical spine was stabilized. Breathing, he was spontaneously with respiratory rate of 18 per minute, SpO2 of 98%. Chest compression test was negative. Air entry was bilateral equal and clear. Pulse rate of 98 per minute with BP of 136, 82 mmHg. Pulse rate compression test was faster, and he had GCS of full score with bilateral pupils normal size and reacting. EFAS was positive in the hepatorenal and pelvic window. Chest X-ray was normal. Pelvic X-ray was suggestive of right-sided SPR-IPR fracture with right iliac blade fracture and right intertrochanteric fracture. On secondary survey called catheterization, patient had the catheter passed smoothly with the bladder bulb in situ, but yet hematuria was noted. So CCD torso with CT cystogram for discussion.
So the main clinical findings and the radiological findings are in the torso, I would jump straight to the torso. I would jump straight to the abdomen for the lack of time. As I'm evaluating the abdomen, what we can clearly see that there is significant amount of free fluid in the abdomen. The setting of trauma, we would classify this free fluid as hemoperitoneum only. Okay? This is a free fluid in the perihepatic space. As I come down, there is free fluid in the hepatorenal pouch, Morrison's pouch, but the main solid organs are appearing fine. Pancreas, the kidneys, they're all appearing fine. What I also see is, if I now just change my window, is that there is pneumoperitoneum. There is free air seen in the peritoneal cavity, so there is pneumoperitoneum which is seen in this particular patient. I go up, I can see further pneumoperitoneum. So once I see pneumoperitoneum, my aim is to rule out and look for a bowel injury. Fine. That is the most common cause for pneumoperitoneum in a blunt trauma abdomen, if it is not a penetrating injury. The other causes may be extension of air from the extensive pneumomediastinum or pneumothorax, but that's not the case in this particular patient. If I come down in the pelvis, since the radiograph of the pelvis already and the clinical findings already showed me that there was extensive pelvic injury. So for evaluation of the pelvis, I can see that there are extensive fractures of the sacrum, zone 2 fractures on the right side. Okay, lower down, I can see fracture of the superior and the inferior pubic rami bilaterally, right? And there is hemorrhage or bleed in the pelvis. The bleed is seen in the form of pre-peritoneal space also in the space of Ritzius. So there is extraperitoneal bleed, hemorrhage, There is pre-sacral bleed also. And as I already told you, there is free fluid in the peritoneum also. So there is a combination of free fluid in the peritoneum as well as extra peritoneal bleed, especially in the pelvis with pneumoperitoneum. In this particular patient, I tried and evaluated to look for all bowel loops, but I could not find any mesenteric injury or any specific bowel loop injury in this particular patient. So my doubt remains that there is a bowel injury which I am not able to localize in this particular patient. But since there is hematuria on the clinical examination and there are extensive pelvic fractures, as well as there is pelvic hematoma which is present, my next aim is to always evaluate the urinary bladder. We evaluate the urinary bladder by doing a CT cystogram, which is by active installation of contrast in the urinary bladder by the Foley's catheter. So in this particular patient also, the contrast was instilled in the urinary bladder by the Foley's catheter, which was seen in situ in this particular patient. What was seen after this is that the free fluid in the peritoneal cavity was now completely opacified with contrast. This contrast is the contrast which we have instilled in the urinary bladder by the help of the Foley's catheter. So there is clearly leak of the urinary bladder contrast into the pelvic cavity. This is a clear marker that there is a intraperitoneal bladder rupture. We also see this better on this coronal reformatted images. The bladder is collapsed in spite of Foley's being in situ. That means that there is a big rent in the urinary bladder, and we can clearly see the contrast outlining the intraperitoneal spaces. There is no extraperitoneal leakage of contrast which is seen. So the extraperitoneal bleed which was seen, was the hemorrhage because of the pelvis. The intraperitoneal contrast which we are seeing is because of the intraperitoneal bladder rupture. There was no solid organ injury, and this is an interesting case to have a good teaching point, that this can also explain the free air in the peritoneal cavity. If there is an intraperitoneal bladder rupture and if a Foley's catheter has been placed, there is obviously some amount of air which gets instilled at the place during the placement of the Foley's catheter into the urinary bladder. If there is an intraperitoneal bladder rupture, that air can leak out into the peritoneum and gives rise to this pneumoperitoneum which we were seeing in this particular patient. Still, we cannot rule out a bowel injury based on the imaging. But once we've identified an intraperitoneal bladder rupture with a Foley's in situ, then I maybe can think that this pneumoperitoneum can be explained by a intraperitoneal bladder. So over to you, Parvez and Preksha.
Yes, sir, we did an expert laparotomy for this case.
Is it really generally how common it is to have the pneumoperitoneum following a rupture of the intraperitoneal rupture of the bladder?
A very good question, sir. In our last 14-15 years of experience of handling trauma patients, the most common cause for pneumoperitoneum is a bowel injury, which is present in up to more than 90% of the patients. If that's not the case, the bowel injury is not there, then the other causes are air tracking from the pneumomediastinum or a penetrating injury. If there's not a penetrating injury, then the only other possible cause is an intraperitoneal bladder rupture. But even in our series of more than around 100 to 150 intraperitoneal urinary bladder ruptures which we have seen, the pneumoperitoneum as a finding we have hardly seen in just 1 or 2 cases. So what we are showing is one of the most rare manifestations.
So if you see a pneumoperitoneum and you can demonstrate at laparotomy it's because of the bladder and pneumoperitoneum on CT, then I think it's a case report.
It's a case.
Yeah.
10,000 of cases what we have shown you. Okay. We can go on to the next case, and I would like to hand over to my colleague Dr. Richa here from my side from the radiology. Parvez or Preksha, you can continue with the
Probably we are on to the last case, Parvez.
Last case is case number 12. Unknown. Case number 12, ma'am.
You want to see case number 12?
अमित नेक्स्ट वालों को ना अपग्रेड कर दो.
Next is case number 12. Unknown patient, 45 years male. He had allergy system, unknown mechanism of injury. On arrival to ED, Area was potentially threatened. Patient was intubated immediately and put on mechanical ventilation. Cervical spine was applied. For breathing part, he has a respirator of 20 per minute and saturation of 98%. Chest bilateral air intake was equal and clear. He had a pulse of 92 per minute and BP of 120/88. He had a GCS of M6. However, bilateral pupil could not be assessed due to the extensive soft tissue injury in the chest. Chest X-ray was normal. FAST was negative in this patient, and pelvic X-ray was also normal. On secondary survey, there was extensive injuries in the face, forehead with fracture of the forehead and the maxilla, which was visible through the wound. CT face for discussion.
Thank you so much. Because of time, I'll just describe the CT pattern phase of this patient. So coming to the CT brain, these are the cranial nose section. Bilateral cerebral parenchyma is appear normal. As we go down, at the region of left frontal lobe, there is a small EDH is seen. This one. There is no significant mass effect is seen on the underlying brain parenchyma. Otherwise, rest of brain parenchyma appear normal. On the bone window, in the calvarium, there are communicating fracture is seen involving the left frontal bone. This one. Even one of fragment is depressed, and that is impinging on the extra axial part of brain parenchyma. Otherwise, rest part of calvarium is appear normal. As we come on the face, there are extensive injuries seen involving the mid-face region. This one. There is fracture of bilateral pterygoid plate involving the medial as well as the lateral pterygoid plates, and fracture of bilateral maxillary sinuses involving the medial as well as the lateral wall, and extensive nasal bone fracture. This one. And associated hemosinus. And these injuries are better appreciated on the coronal reconstructed images. I'll show in the.
Richa, in this view, can we also comment upon the optic nerve? Because on the left side, the eyeball is lying outside.
The bone window, here we can see there is a fracture of bilateral pterygoid plate involving the medial as well as the lateral pterygoid plates. Extensive mid-face injury involving the nasal septum, medial as well as the lateral wall of bilateral maxilla, fracture of lateral orbital wall, and fracture of right side zygoma. So these represent a Lee-Ford injury. The fracture of pterygoid plate, that is the essential component of Lee-Ford fracture. I'll just demonstrate on the VRT images. So these are the VRT volume rendering images which shows extensive injury of nasal septum, bilateral maxillary sinus involving the medial as well as the lateral wall, and also involving the palate as well as the alveolar ridge. So if we see on the right, so involvement of I just. So involvement of medial maxillary sinus and the lateral maxillary sinus fracture with fracture of the part of the zygoma that represent the type 2 Lee-Ford, and the fracture of the alveolar ridge as well as the palate that represent the Lee-Ford type 1. So there is a type 1 and type 2 on the right side. And fracture of medial and the lateral and type 2 and type 1 and type 1 on the left side. So type 1 and type 2 on the left side as well. So there are type both sides there are type 1 and type 2 Leeford fracture as well as extensive fracture of nasal bone. In this
Thank
case,
you.
the zygomatic arch is appear normal, so this is not Leeford 3. The essential component of Leeford 3 is a structure of zygoma and zygomatic arch, which is appear normal in, on either side. In the soft
Thank you very much, Richa. Thank you so much. And you have shown a very nice VRT image of the face. And I think all the participants would have appreciated that they can visualize it like a normal skull in a VRT image. So by this CT, we come to the end of this radiological session. And thank you very much, Dr. Richa and Professor Atin, for showing us such wonderful, elaborative images of all the CT scan and for a wonderful discussion by all the faculty. And thank you, Parvez, and thank you, Preksha. So now I'm handing over the session to the